finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Hey everybody, welcome back to the final week in October of BS Free MD. I am your co-host May Hindmarsh if you're just joining us for the first time. And here's my assistant host who is on the last week of his sober October. Any words for us?
Well, all I know is in a week they'll be slurred.
Slurred.
Yes, because it won't be sober October anymore.
You should be sharp, focused.
Oh yeah,
with us.
I'm so focused. It's just insane. Like I'm amazed that I'm not actually cutting the screen in half with my focusedness. But
Well, this week we're super excited to bring you an episode called Simple Medicine with our guest, Dr. Rob Barkett. But before we get into the nitty-gritty of Simple Medicine, we are excited to bring you a word from our sponsor this week, Oregon Valley Farm.
Yeah, so we've been really into this, eating clean, which I absolutely hate that term, but actually eating real food. And we're big believers in eating, lots of protein and lots of animal products. We think that that's true. We're not quite to the level of Dr. Anthony Chafee, but we're kind of someplace in the middle there. So it's really important that the quality of what you eat and the quantity and the components all match up. And, you can get lots of protein, you can get lots of shakes, you can do all sorts of stuff. But really, if you want to eat real food that's produced properly, we really love Oregon Family Farms. They are absolutely amazing. They have pasture-raised beef, pork, and chicken. We ate the chicken and we were absolutely completely blown away because it actually tasted like chicken from the 1970s when we were kids.
Yeah.
I don't mean it was chicken that was left since the 1970s.
No, let's clarify that.
But literally chicken, like
it's chicken like chicken used to taste.
Because they let chickens do chicken stuff.
Yeah.
Like walk around and like not be stuck in these corporate farms. They're out walking around doing chicken things. I don't know, what do they do? They trade chicken
stocks? They're not pumped full of corn and soy products, that I do know.
And hormones.
Exactly. So Oregon Valley Farm is located in the Willamette Valley out of Albany, Oregon. It's family-raised business. They actually outsource all their meat to local farms in the Oregon, as well as Washington and California area. And they have high quality grass-fed and finished antibiotic and hormone-free beef, pork, chicken. And you should visit them online at Oregon Valley Farm. You can get your custom order delivered right to your door, which is really awesome. You can also pick it up if you are local and save a few dollars. So
and if you sign up, you get a significant, what is it, like a 30% discount? Or
yeah, so they have actually discounts all the time. Every week when you're on their email list, specials vary every week. You can get discount boxes on bulk orders of beef and pork and chicken, or you can just order one order of chicken breasts at a time if you'd like, or one steak. So you can mix and match any way you want. And they have subscription boxes as well as regular sales. And I think if you're a first-time customer and sign up, then they have a discount code for you for
if you order over $149, so $150 worth of meat, which it's not hard to eat. It's actually not hard to eat.
And they even have recipes on their website as well. So if you're looking at the video here online, you can see some of the photos, but I'll put the link in the show notes. It's Oregon Valley Farm. It's a great family-owned business, and it is real healthy meat without all the crap in it that I think from Costco to your favorite box store it has now. So,
all right, let's get on with the show. Simple Medicine. Excellent interview. And you'll really enjoy Dr. Barkett and Barkett, I should say it correctly. I get confused. It's like I want to put him in a barbecue.
Is that the lack of alcohol talking?
Yeah, I know. It's a complete lack of alcohol. It's ridiculous. And we turn into the two guys from the Muppets where we just like rant and rave about how crappy stuff is. So it's awesome. You'll enjoy it.
All right, everybody. Welcome back to another episode of BS Free MD. Tim and Mayhan Marshir, if you've not met us before, you're a BS free couple. We're happy to be doing video. This is the third week in a row. And this week we have, our guest who, this is really cool. This is right up our alley. The things that we would say bitch about all the time at home and to each other and at work. And I'm thinking, why didn't we write this book that our guest today has written? Because it's all the things we believe. So this is going to be now a three-way conversation about healthcare. So our guest is Dr. Rob Barkett Jr. He is a family practice physician on the other side of the other.
Internal
he is a internist, but doing general care, and he's on the east side of the country, and he's been in almost as long as we have, for 30 years, and he has written a book called Simple Medicine, basically targeted to both, I think, the physicians in primary care, but for the patients as well, who need some direction in either common medical conditions that we all want to Google, and to talk about the history of primary care and medicine in general and how it is completely changed, as we always talk about. So without me messing up anything further, I'll turn it over to our guest, Dr. Barkett, and let him tell us a little bit more about himself and the book. So welcome to the show. Thanks for being here.
Well, May, Tim, thank you so much for having me. And when I saw BS Free MD, I'm like, oh my God, we must be related. There's got to be some genetics involved here.
I think we have lots of relatives across the country that we're now finding out that yes, there's a lot more of us BS Free MD relatives out there, right?
Right. So I'm pretty much a Midwestern born. I was born in Mansfield, Ohio. I attended Purdue University on a golf scholarship and went to Thomas Jefferson Medical College in Philadelphia for my medical school. Graduated there in 1990, went to Riverside Methodist Hospital in Columbus, Ohio, did my internal medicine residency there for 3 years, and found my way back to Mansfield, Ohio to join my father, who had been in internal medicine practice since 1967. And I was fortunate enough to be led by a smart man, a very common sense man who practiced medicine when doctors were truly doctors. And we practiced 13 years together, and he retired in 2006. I've maintained a private solo practice just by myself. We've got multiple major hospital systems from Cleveland and Columbus, plus 2 local ones that like to buy out family practice and internal medicine practices. And I've resisted because I think medicine should be practiced by the physician and not corporate people. And I guess I'm one of 2 lone dinosaurs in our county.
You are a rare and dying breed. I mean, really, because we started off actually in a group though, but as time went on, you're right. Big corporate comes along and starts buying up and snatching up the businesses and it's a difficult thing, as you know, to be able to survive. And everybody's kind of just caved in and been bought out. And in our neck of the woods, in primary care, standalone physicians that have been practicing for a long time just don't exist anymore. There's a lot of new direct primary care groups, popping up. The theme now is kind of, I think a lot of doctors realize that if they're going to survive in primary care, then the concierge practices are starting. But I call this old school because I think we've got a lot of wisdom and wealth of knowledge, and that you accrue over time with all the patients we've seen, the experience we've had, and it's very valuable. And people being on their own is rare.
So do you take insurance?
I do. I did when my father left. I didn't know how I was going to manage. And I did look at concierge medicine. And in our demographic here, we're pretty much we're smaller town, but we did have General Motors, who has left, the steel mill, which got cut back. So we're kind of, our city was kind of dying a little bit. But I do, and I think I carry all the national commercial insurances, and that's about 35 to 40% of my practice. And then Medicare and Medicaid, I feel since I was born here, it's my responsibility to take care of everyone. And I just have a few cash paying patients.
Are you still doing hospital work?
No, in 2006, I did not, being by myself, could not continue to go to the hospital and round every day of the year. And unfortunately, I did give my hospital practice up to the hospitalist program.
Yeah, it's an interesting point though, because both May and I did hospital for years. I actually did some hospitalist shifts for a little while. I delivered babies. I did, we did some death investigation stuff for the state coroner, and it's amazing how much medicine you learn. Like you really like, that first 10, 15 years of my practice, I was in the hospital a lot, and I'm glad I was, because I learned who was sick. And when we fragmented all of this care, you have a hospitalist, they have laborists now. You go to, you see an OBGYN, and then you go to have your baby, and somebody just shows up that just sits there and pulls babies out all day. And that's all and then they go home. It's like, it's all shift work. It's amazing. Like this, continuity where I would take care of, a mother, and then her child, and then her, the grandparents, and then, on and on. Like that just is, gone.
Then there's pros and cons to that, which we can get into maybe and discuss. But because, there's the lifestyle sacrifices that have to be made for a doctor to be the one. You know what it was like delivering babies. Or you're right. If you're on your own and now you've got a patient practice that's maybe, say, elderly, or has a certain type of illness that you specialize in, and there's somebody in the hospital all the time that you have to round on. That's a big burden, and it can be when you're independent. So there's
I would say
pros and cons.
I see, Tim, oh my God, you took words right out of my mouth. But from my standpoint as a solo practitioner, lifestyle was completely improved when I did give up the hospital work. And that way I could be in my office. I wasn't getting torn away during the middle of the day for chest pain or an MI or acute bowel, which we used to be, but with my dad or I would always cover. And then especially rounding it at night, even though we were in a call group, wanting 1 out of 6 nights, you're up all night, and you kind of know how well, I don't think the new physicians know what it's like to be up all night. I think they're only allowed to work like 16 hours a day, where, we were up 36 hours a day. So maybe us old schoolers, could put up with that, but how you felt the next day. And your biggest point there, Tim, was experience. That's why physicians are physicians. We have spent 4 years in medical school, 3 years in residency, on call every 5th night. And the only way you become a confident doctor is by seeing every condition over and over good. The common presentation of common problems, the atypical presentation of common problems, and then the zebras. And you just can't do that without experience. And I think that's what's totally separating now the physicians from nurse practitioners, or nurse practitioners and physicians assistants. They just don't have the care, the continuity of care we've had through the years, and the number of patients we'd be able to see, where we can witness by looking almost at a patient who's sick and who's not sick, and what you've done in the past, rely on that experience.
Yeah, volume, you're right, presents all of those things. It's we would, people would say, well, yeah, talk about the good old days doesn't mean it's better. And I'd say, no, absolutely not. But the reason that those internships and residency years we had those 36-hour shifts, and even when you were working, and it was a way to train us to get the amount of volume in and see a number of sick people, so that we had that experience. You're right. I don't want to do that for the rest of my working career life, because I'll be dead from lack of sleep. But just as time goes on, the wealth of knowledge, the experience, all the things that you said just accumulates. And now, oh gosh, I don't even know. I'll let you take it from here, but you're right. With the mid-levels coming in primary care world, especially, and not really acting as a physician extender, but being allowed to take over as far as primary care independently, it's changed the dynamic completely for patients.
Well, I think there's a group of internists in a town about 18 miles from us, and they were absolutely outstanding. They had a small hospital, I don't know, 75 beds, something like that, and they just ran the hospital. One of them was a nephrologist, but would still see primary care patients. One was, I can't remember yet. They a couple of them had subspecialties, but they would still do primary care and they would still take turns in the hospital. That was so unbelievably efficient because they would never refer a patient out. And I mean, if you got referred out of that group, you like no one was going to figure it out because they had such a brain trust and so much experience because they did absolutely everything. Now, virtually all of them are gone. They're all retired. They're all in their late 60s or early 70s now. But I remember thinking about it and I go, this was the highest quality and the most cost-effective way to take care of people. And there's something that happens in less experienced physicians and less experienced, mid-level providers. When you haven't seen that volume of really sick people where you've stayed up all night because you're scared, because you're calling somebody in another city to get a, backup plan, and you really understand who's sick. When you don't have that, you see a patient, you immediately refer them, or you see a patient and you immediately do, advanced imaging or whatever the case may be. And I've seen this with physicians, not just mid-levels. And that is exceptionally expensive. I mean, how many visits can somebody see you for the cost of one MRI, right? I mean, it's unbelievable. And I used to do some utilization management and I would see this over and over and over and over again. And it's like the patient wants, it was just like a triage clinic. People come in, it's like, I want an MRI, I want a CT. Okay, next. I want to, and I'm like, well, and then you wonder why healthcare is so expensive. I'm like, because we're doing a bunch of stupid stuff that doesn't need to be done.
Well, I've witnessed everything since I was an 8-year-old boy. My father was one of 3 or 4 primary care people. Our emergency room was staffed by the 3 or 4 primary care doctors. That we had no subspecialists. I would go around with that on the weekends. We would make house calls, and we know that he was taking care not only of that patient, but their parents, their kids, their cousins, their neighbors, and you really develop a community and a family feel. And this day, and we had probably over 60,000 people in this town at that time. Now we have about 44,000 people, and there's 3 emergency rooms, go from 0 to 7 urgent cares, and then which are primarily run by the PAs, nurse practitioners, even emergency rooms with their physicians. And unfortunately, these people are using these facilities instead of their primary care. And just the expense, I would like to know, between one sore throat visit, they go to the urgent care and they've gotten, CBC, blood work, CAT scan, or lateral X-ray, make sure they don't have epiglottitis, and they do this and that, and it's either a virus or a strep. And I'm like, oh my goodness, what they either don't know better, or CYA, cover your ass medicine, but it's just a joke. And you guys know what it takes for us in the primary care setting to get an MRI or a CAT scan. You got to give up your first child. But my God, you can go in for a hangnail and you're getting MRI'd because you slipped and fell 2 weeks from your head to your toe.
Oh, we know it. We know it. I mean, the one case that I always bring up and talk about is I was working and I saw this patient and I was just flabbergasted at the expense because they came in because there was a lump on their arm. It wasn't really bothering them, but it was growing slowly. And they saw a mid-level who said, oh yeah, I don't know what this is. This is kind of worrisome on the back of your tricep, this thing that's non-painful and slowly growing. And they got an ultrasound without much description, the radiologist kind of looks at this thing, and whoever the radiologist was they're like, well, I'm not certain, this could be solid, maybe get an MRI. And of course they did, and lo and behold, it was a lipoma. All of that, which I just shook my head at, because I thought, wow, like, people wonder why healthcare dollars are so expensive. And
But yeah, but it comes from the most destructive degree in the history of medicine. And the most destructive advanced degree you can get in the history of medicine is not lawyers. It's not a JD degree. It's an MBA. We are being bludgeoned to death by MBAs. And so an MBA looks at a provider, and they look at you, and they don't take into effect, the fact that you're going to see people for less money because you're not going to order tests or whatever. And they say, I have to pay Dr. Barkett 100% of, his wage. I can pay somebody else 60% or 70%. Therefore, I want more of the 70% and less of the 100%, and I'm saving on wages. Well, you may be saving on wages, but you're going to be taking it out by orders of magnitude on the back end. And I fail to understand this. I mean, MBAs are trained to do business. They're not trained to take care of people. I mean, this idea that hospital systems actually care about taking care of people is silly. They care about running a business because they're run by business people. And if business people don't care about business, they're not doing their job. And like, it just seems really simple to me. But you say this and they're like, oh no, it's patient care and it's press gainy. We want people to, give us feedback and all that. I went into a meeting and I said, I'm being judged by somebody who's a meth addict. Because every single person that would come into the urgent care that we would work at would be either telephoned or emailed for their opinion about their visit. And I'm like, what?
Yeah.
Like, are you kidding me?
Well, that's funny. I write this in the book. One of the bonuses for this health system in Mansfield, the big health system from Columbus, was their Press Ganey scores. And if you read what the outcome of the Press Ganey scores was, the higher the Press Ganey, the more bonus the physician was going to get. But the conclusion was the higher the Press Ganey score, the worse the patient outcome. And we are not their little friend here, and these meth heads and drug addicts and narcotic abusers, and you don't give them their narcotics. Well, there goes your 0 Press Ganey score. There goes your Google, review
rating.
This guy, he's the most uncaring doctor I've ever met. He won't listen to me. He won't do this or that. And you know what? I can put my head down and sleep at night. I am not here to be their big brother, or I'm more like a parent, I like to say, where if, I'm not going to let the inmates run the assignment. I am going to do what's best for that patient. And I'm not going to give in to the cries, the yells, the pressure. And that's what Press Ganey does. And that's what corporate does. And I know probably another reason I'm not, owned by a house is because I would be fired in the first half hour. I may be politically incorrect. May not want to ask an 80-year-old veteran, what gender he prefers, and may have an off-color joke here or there.
We should define what Press Ganey scores are for people that aren't in medicine or that haven't.
Well, it just means
how
enough. Much you like your doctor and how much you liked your doctor's experience. And you got a bunch of kiss asses now so worried about that they will give in to what the patient demands. A good doctor will have a mid to low Press Ganey scale because he's doing what is best, and that outcome of that patient will be significantly better for a doctor with a higher Press Ganey score.
See, there's the secret. So when people go online and look at reviews of physicians and they're looking for the ones with the 5-star best Google reviews, they should be wary. They should be looking for the one, you're right, with the 2-star, and some nasty comments. Because as we said, most of the time when people are happy, they walk out, they don't want to deal with a survey. They don't go online to write it's just like, yes, business as usual. It's only when you have failed expectations. You're right. You get your narcotics. You don't get a Z-Pack, or you
Right.
think you know what's best. Then you go in there to bitch and blow out the doctor. And I'm like, what other profession though
No,
would respond this way? Can you imagine
everyone
if
does.
every
Everyone
time,
does it.
no, the architect, say if I'm building my house and I'm like, well, this is how I want it to look inside. I want that wall to come down. And the architect says, no, that's a load bearing wall. If we take that down, your roof caves in. And I'm like, well, damn it. I don't like how it looks. You suck. I'm giving you a bad review. I mean, can you imagine?
No, I know, but somehow this got infected in all of business. Okay, like I go to a Harley dealership and I pay wildly overpriced rates for a part, but it's a genuine Harley part and it is absolutely bulletproof because they do make really good stuff. So I go in there to buy a part for my bike, right? I buy an air cleaner lid, and then I get 14,000 emails rating my experience, and it's like, I bought a freaking air cleaner lid. I didn't
How
have
much
an
joy
experience.
did that
I
bring
didn't
you?
have an experience, you know.
You
Like
should have.
they weren't serving me drinks and giving me a massage. It was a part for a motorcycle, and
But
some.
that's what's happening in medicine.
But
We're
yeah,
trying
but
to
then
turn
but
it
then they
into an
took this and it
experience.
went even more insane because it's like medicine is a service industry. Well, of course it is, but it's a very different service industry than a massage parlor or a Harley dealership. But somehow everything is the same because all of these geniuses went to the same freaking MBA school. And it's just like, it just is beyond comprehension to me. You know, so tell us
Yeah, tell us about
your
your
book.
book. And it's Simple Medicine. And when did you publish it or write it? And what was sort of the
Well,
genesis behind wanting to get this out? I mean,
well, the impetus was I've wanted to write it for years, and us older doctors would talk and how, now that, just say, not doing hospital medicine, and these hospitalists don't even talk to me. I know the patient the best. I don't know when my patient's admitted. I don't know when my patient's transferred. If there's surgery, the younger ones don't call you. You may want to get a fax. And the other part is being a hospice physician, and I'm also a nursing home director. And plus I get a lot of referrals from other specialists, and then through the years, doctors retire, and I'm like probably the oldest practicing primary care doctor here in Mansfield now. But and I would see the mismanagement of patients. I mean, people who think they are getting the standard of care are just not even getting half of it. They are not getting their appropriate vaccines. They are not getting their appropriate cancer tests. They have a condition, and I might as well just say diabetes, because that's one of the most common. And there may be on two of the same blood pressure medicines, and it's not even an ACE or an ARB, or their cholesterol levels not low enough. They're not getting their statin. They've not had their eyes examined or their protein examined, but they think their doctor or their mid-level is giving them great care because they're just nice people and they spend a lot of time with them. So that was in the back of my mind, but of course, doing those other things, I didn't have the time. Then COVID hit. And then during the winter, I love watching my basketball. I like to travel, like to go out, and we were locked in at home. And I always do review. I review my MKSAPs every winter. And so I just got an idea. I said, let's review. Let's do hypertension day. But I went to the old-fashioned notebook with my old-fashioned lousy doctor writing, and would write a review of what I felt was a standard of care algorithm. And then one day maybe I do vaccines. One day I may do depression. One day I may do chest pain. And I just started writing. I would review and I wanted a reference guide for patients to understand. I wanted it in what we call layman terms. I wanted any 8th grade person to be able to be more educated, have increased literacy in their own medical care. Because I know, as much time as I spend in here, and you start talking diabetes, high blood pressure, strokes, heart attacks, cancer, these people's minds are blown. Heck, my minds are blown when sometimes I go to the physician. So I wanted them to have and not Google. This Google stuff is awful. Patients coming in, well, what's your problem? I have a sinus infection. I have kidney cancer. I have a peripheral whatever the way they pronounce it, neuropathy. And I'm like, no, let's step back, Jack. What are your symptoms? So you combine those things, and then COVID, and then the final straw was I have this educated man, and came in twice a year, never really complained. Well, he called that morning and he needed to be seen right away. And we got him in. He's all red-faced, and he goes, Doc, I'm dying. I go, why? He goes, I have renal cell cancer. I go, how do you know you have renal cell cancer? Well, I peed blood last night. I go, what was it today? It was clear. I said, well, let's just talk about the common causes and not, go jumping off the cliff quite yet. So, of course, we talked about it, ordered the ultrasound and stuff. He had a kidney stone and all that. So the following week when he came in, he brought me in a sign, and it said, don't confuse your Google search with my medical degree. And I was like, you know what? COVID, that. And actually in the book, my wife was listening to Oprah Winfrey, and Lady Gaga was on, and she was actually talking about her childhood and some, sexual abuse. And I'm like, oh my God, she's so raw. And her reasoning to go public was if she could help one person. So it's kind of a roundabout way of, disillusioned with medical care, patients not getting what they deserve, and patients not having enough education or literacy on their own problems for overusing Google. And I don't know about you, but I even sometimes go to, the Mayo Clinic or WebMD, and I'm like, what the hell is this? Nothing's in English, nothing even to the point where I want to help explain it to the patient. So I took all those things, started writing in my notebook, and about a year later, 6 months later, it's finished. I got it typed up. Then I had to find a publisher, got one in New York. And then a year after that, I was published February 1st of this year, 2022.
Well, congratulations.
Well, thank you.
I have many books inside of me, but the biggest thing, and I think many people do, but just to get started is like the biggest hurdling block for a lot of people. And it's a pretty cool story how you're just literally doing your own homework algorithms, writing down points for your own CME, continuing medical education. You're just learning, and you're like, wow, look what I'm doing. I'm making this in an easy to understand format that I could just put that out there for my patients. And voila, I love it. So part of the book, though, is isn't it a little bit of a more I would say dedicated more to physicians and about the decay of the physician, like you said, physician relationship, and how we've come along. What are your, I'd say, sort of top, and not top three, but biggest really kind of points on that? That maybe we haven't sort of covered already as we're bitching away about some mid-level stuff, but
I think one of my goals was they don't teach us in medical school or in residency, really, these young kids, how to run a practice or really how to behave, I don't think. So the one part I do discuss for a young physician is, how they should run a practice. And I discuss my front office girl, my nurses, how the algorithm should go about the vital signs and getting the patient back, and telling them how you actually have to talk to patients. Right now, that computer, I could whiz it out that window with every patient visit. Luckily, for the majority of my patients, they came in, I had their little chart, wrote down a few notes, and went back, dictated in something I could even understand or anyone could understand, and on to the next patient. Now you got to come in with the I just carry my computer, but it still distracts from my conversations with the patient. I try, like the best I do, to tell each doctor, hey, ask an open-ended question, shut up for 2 minutes, let them talk. And now I said, if anyone ever can teach me to do that, then I'd be a better man. Uh, and so I try to tell them, when you go in there, it's not about the computer. It's not like charting down that their family history, or, oh, is he still smoking, or is he whatever, you have to, press to get your billing up there. And to really try to become not their friend, but have a familiarity with each of your patients, how to explain things to them, not once, but twice. And when they leave the office, what they should expect. I even tell them, really in an outpatient setting, what should you dress like? I mean, what should you look like? I mean, I think you shouldn't be in scrubs. I don't think you need to be wearing sandals or tennis shoes. It's not a coat and tie like it used to be. It's a little more casual, but it's at least, presentable. And then I like to talk to them about the other ones about communication. And as I've stated, communication is god awful. It just sucks among physicians these days. There is none. I kind of stated before, amongst the subspecialists, and especially in my situation, they think they can fax me or send me a note. Well, I'm not even on the same system. And like all across the country, nobody can really talk to anybody. Everyone has different systems. I mean, I'm a quarter mile from the hospital and my system doesn't talk to their system. And then every time we have a specialist here, they just seem to can't figure it out. Unless I can see what's done in the emergency room, but that's it. But to have, going back to my father, when I did rounds with him in the 70s and early 80s, there's the doctor's lounge. Everyone would go there for their coffee. Everyone sees their own patients. They talk about their own referrals. If they don't talk about it there, they call each other up. They I think they had beepers then, or just the operator at the hospital, or a phone call to the office. Everybody knew each other. The doctors, I tell you, I knew all the OBGYNs and the couple surgeons, and they all knew each other. I knew their kids. We went to school together. We partied together. My parents, had New Year's Eve with them, or their women's auxiliary bridge club and the country club. Everyone was in this community. Everyone talked. They knew each other. Yeah, it's not like they had to like each other, but they were a community. Now we are most of the physicians are subspecialized. They don't even live in the community where they practice. I don't know any of the young people anymore, the specialists. I know still the old cardiologists, infectious disease surgeons, pulmonologists that when I was doing hospital work. But now that I haven't done hospital work, I don't know these new people, and they don't make it a priority to get to know me. And when I do meet some of them, they come to town. I just have one request: call me when you have any questions. It takes 1 minute. I don't want faxes or text. Just give me a call. And there's a couple people have heard me go off the nut on them because, I wasn't notified. I had more information. I had my own even hospitals that I would like to refer to. And patients have to know that just because they're in the hospital, they think that their primary care knows what's happened. That's just not truthful. When they get out, you're lucky, which now actually the one good thing is when they do leave the hospital, commercial and Medicare, Medicaid require, if it's a serious problem, to see their primary care in 1 week. If it's not so serious, 2 weeks. So I do get some information that way. And then
when I hear, you talking and it's all our language about how, the gaps in communication, the changes and how it used to be in the connection. And, we're all bantering about the old way and how we were trained and how things used to be, at the, we definitely don't want to come off sounding arrogant about it because things change, times change. You hope it evolves for the better, but ultimately, this is about the patient and patient care. And I get that as we get, 30 years in practice, that's a long time. Things evolve. The tech is one thing that I'm with you. I want to just throw it out the window and use paper. But the communication part is, a really fascinating thing to me that you're right is horrible. And I'm thinking, is it just, that we are dinosaurs, that things change? I think of our kids. I think of the generation of kids growing up from like toddlers to, I don't know if you have grandkids, our kid, how they communicated was so different. We would get all over our kids to pick up the phone when it rang than when we had a landline. No, they didn't want to do that. They'd have to talk to somebody. And we laugh about it, but the generation and even the young physicians that are coming out now, their way of communicating and they've grown up with is different. It is through tech. It is, through text. And you're right. The whole, now that we're not doing hospital rounds together where we're going to the doctor's lounge and drinking a coffee and eating a donut and getting to know everybody, where you have that community, it is all separated. People have wanted to have, work-life balance, which means they go to work and they do their shift and then they get the hell out because they want their life balance and they want to be able to go to yoga class and pick up their kid from daycare and still be a doctor and do their thing, which means less interaction with other clinicians and less. So as
Yeah, but
people evolve. Oh, but I'm saying, I'm not saying which one's right and which one's wrong. I mean, it's a bit of both, right? You can't have one without, giving up something else. And this is the situation we're at.
I call it the Oprahfication of the country. And it's this idea that you can have it all, right? You speak to the universe and the universe speaks back to you, and you will find your passion. And Eckhart Tolle will, make all your problems get better, and you'll be rich and you'll attract wealth because you speak it into your life and all this. So then these people but then you're doing a job that's super hard that you have to give up your entire young adulthood to do. Like you have to completely give up your young adulthood to be trained as a physician. And then it's really long hours and you deal with sick people. Okay. Which means people that are unbelievably distressed, and some people die, and really hard things to deal with. And you're supposed to have work-life balance, and it's all supposed to speak into you and give you all of this satisfaction. And I'm like, no, it's a marathon. It's painful because that's the way life is. The satisfaction is understanding that you can do something at a very high level that not everyone wants to do. And you get to have a connection with people in the most humane, most human way possible, sharing the birth of their child, sharing the death of their parent. All of these things are immense privileges that we get to do as physicians, and we should see it as a privilege. And instead it's like, well, no, I need work-life balance. Well, screw your work-life balance. You're a freaking doctor.
But you're
not an accountant.
But it's permeated, even into family practice. So we helped teach residents in family practice, and they would come through on this. We were working at an urgent care together. We had a connection with the medical school locally, and they would do their urgent care rotation. These family practice residents would come through, and we were very busy urgent care. We could see 100 patients a day in a 12-hour shift between two docs. And so we're flying through there, and, the winter flu season, and we're trying to get these guys busy and help us out. But long story short, we would say close at 8, but come 6:00 at night after 10 hours, a resident would say, and this was more than one time, they'd look at me and go, I am just tired. This has been a really long day. And so I think I just need to go home now. And I would say, well, that's nice, but no, the shift is not over and you don't just get to go home. I don't just get to go home. This is part of training. Well, we've been learning in our culture, in our group, in our residency, that there's boundaries. And I'm like, I was just like, if you need to go,
boundaries. I hate this stuff.
I'm literally like, yeah, just get the hell out, because this is not going to be helpful. You not wanting to be here. And, I'm like, maybe you need to rethink your career options. Honestly, because this is what it is.
And that's exactly who I want dealing with me when I get in a car wreck and they have to use the jaws of life to get me out. And they're going to wheel me into the trauma surgeon who just,
has had a
whose puppy is ill. And they just are not up to the task of trying to fix my liver laceration or pull the little tiny pieces of bone out of my spinal cord. But come on.
But if this is how they're setting up programs, and I read things online, I'm following different groups, and burnout in physicians and the chatter and the talk, then I'm thinking, yeah, there's no wonder that docs aren't really not even communicating with one another. They're there to do the banker's hours. Not going to stay that extra 20 minutes when they've got a patient that's the last one of the day that's broken down in tears because their marriage is falling apart. It's like, well, come back next week when I have more time. You know what I mean? It is a totally different paradigm we're in, and I don't know what the answer.
Well, I think
I don't know.
I
Maybe
don't know
Rob
I
knows.
don't know what the answer is. But I think doing hard things well and taking pride in that doesn't burn you out. I don't think hard work burns people out. I think meaningless work burns people out. And I think the reason these young doctors are getting burned out, and the reason May and I got burned out, is we were doing stupid stuff that and that's my next question for you. I mean, you're an independent guy. You do take insurance. Are you doing all the metrics? Are you ticking all the boxes? Because it is very lucrative in primary care to make sure that every I is dotted and T is crossed and every regulation is met. So how are you dealing with that?
Yeah, that's a good question. I've, I guess, had this computer since 2012. I've kind of become pretty good at it, and I've kind of learned how to play within the system. And I'm so familiar with my patients that I actually preload probably 70%. You're not allowed to cut and paste, but if it's the same well visit, and then so I'll go through and preload a look, what, and I already know why they're here, and then I review the chart, and so I put what I know I'm going to do already. I try to do as much as I can in my office to be as prepared as I can when I walk into the room. And that way, I'm not pounding this keyboard, like a piano player the whole time, and I can get most of those, like you said, the I's dotted and the T's crossed. But I just joined an accountable care system.
Mm-hmm.
And what they're going to do is I've teamed with them where they look and see, hey, where are my gaps? Because I know, as much as I want to say, hey, people aren't getting the great, is there a colonoscopy not done on time? Has there been a shingle shot that I'd not recommended? Or has there been one of the things that really should be done in primary care prevention? And so I've joined this accountable care organization where they oversee me, and they tell me which patients are appropriate, and they make sure that I have their A1Cs done. I what their mammograms done on time, and so that's going to help me a lot. And like you said, the more, unfortunately, the more you punch, the more you get paid. But I don't really now. I've cut my office hours down a little bit since I have those other jobs, which are way more lucrative for the time and effort and acuity that you do. I think all physicians should try to do some medical thing outside the office, which helps decrease burnout. And but my patients know. I mean, like my dad said, one, he was a workaholic, and he's like, "Hey, Rob, he goes, if people call in, you got to get them in today." I go, "Why is that, Dad?" Because he goes, "Well, if they're sick today, they may not be sick tomorrow." So part of getting them in, see them, and work on. But if I see 24 in a day, fine. If I see 44 in a day, I'm not leaving, and I don't have to account to anybody. And I think, like, again, for burnout, I do talk about burnout. If you like what you do, I don't know if there is burnout, but you have the work-life balance is like, my friend calls me tomorrow and says, "Hey, in the afternoon, there's a good golf tournament, a good golf course I want you to play." I'm like, "Well, I'm gone." Luckily my patients will know that. And then, we'll move them to the morning, the ones that need to be seen, other ones we reschedule. You schedule your vacation times after about 3 months, I need a break.
Right.
And you do that, and you have to keep your hobbies, whatever those hobbies are. You have to have date night with your wife. I mean, those are all things about home life balance that really shouldn't be tied to the number of hours you work in a week. Take your allotted vacations. They're allowed more now than I ever took, and do something you like. and set a half day or day to yourself where it's just you, no spouses, no kids, no work, and go into whatever space you want to go to.
I love it. So I'm going to flip sides a little bit because actually I think more than 50% of our listener base is like a patient base, not medical. And I know there's two things that is really, I mean, people are going to be asking or really burdens them is patients, myself included, have trouble getting access to a primary care doc. I don't know what it is on that side of the country, but there's a shortage because nobody wants to do primary care anymore, or it's getting filled with the mid-level practitioners and people. Some do want to, see an actual medical doctor, DO. I don't know if you touched on this in your book at all, but what do you suggest for finding a good primary care doc or advocating for yourself in order to get in instead of
Well, the
specialist
first,
shopping? Yeah.
I have to go back to the book. I think the book is a great way of keeping people out of the urgent care center, keeping them, making sure they can realize that their problem is not a need to be seen today, tomorrow, next week, and I go through whatever problem you have, and I'll go through the most common things that we have seen and what are the buzzwords that get me or a doctor excited and what are the words that don't get me excited. And
Mhm.
so if you have chest pain, what are the real good signs that, hey, am I having a heart attack or not? And this is going to help you out 90% of the time. If you have an acute abdominal pain or diarrhea or constipation or peeing blood or low back pain or a fever, sore throat, I mean, whatever, headache, which is very common. So if you can, every patient, just go to it, see what the most common problems are, see there where, hey, do I need to go to the emergency room because doctor says, man, this isn't good, and I don't want to be dying here, or what can you just hold off on? But again, here it's a tough when people leave my office and they're moving to another community, could be a big city, small city. I first recommend, obviously, an MD or a DO. I recommend when they get there to talk to people because I think word of mouth says volumes for that particular doctor. I don't go for Google reviews as you say. I tell them to look at their where they went to medical school, where they did their residency. Is it fairly well known, or is it some place over in Uzbekistan?
Yeah.
And then word of mouth. But unfortunately, it's the same problem here. I don't have any good things to say about how to get in quicker for that examination. It's just a problem nationwide. But I would think if there's a solo practitioner, someone that actually works, they what do we say? They eat what they kill, is a little better than someone who's punching the clock and working like a banker.
No, I mean, I agree. I think that that seems to be the wave of the future, that anyone who really has a big heart for primary care doesn't fit into. So there's some people that do fit the big systems, but um, people doing the concierge medicine, direct primary care, I mean, patients have to realize that they're going to get like top-notch person. I can't, I guess, judge the care, but they're going to definitely have someone who's got their best, they're there for that patient.
Right.
Because the model that they've set up, and they have the heart for that. So that not to shy away from those for sure.
Well, yeah, and I mean the common sense part of direct primary care is it's honest because you're paying cash, so the consumer is paying the producer of the service,
Right.
and there's nothing in the center. It's like, how do all these C-suite people get paid in healthcare? Well, they get paid by what we do as physicians. They pay all the nurses, they pay all the executives, they pay them all by what we
Off the
do,
physician sal or billing. Yeah,
but
off the
by what
physician's
we
billing.
bill, because
Yeah.
they can't submit a bill for a service because they don't have a medical license. And people forget that. It's that,
The doctor's work is supporting their salary, basically. I'd say the nurses' work too. I mean, but you're right. C-suite people only exist because of the doctors and just taking care of patients.
And the fact that physicians have given that away, it just never ceases to blow my mind.
Yeah.
It's like, you know, to get an MBA, you don't have to go to school for 10 years. Okay. Or 12 or 15 if you're a subspecialist, you know, in some area. And yet we gave power to people with a fraction of our training and zero of our experience. And we gave it away. And I don't get that. Like, I don't see the American Trial Lawyers Association just giving away all of their power. They seem to do the exact opposite.
Yeah.
And somehow we're like, well, you know, this place has really good benefits, so I'll just do what I'm told. I'm like, really? Like really? That's why? Like, you're easy to buy off. And maybe that's why I'm not in any of these systems, because I'm probably unemployable at this stage.
You've tried out all the systems.
Yeah. Worn out my welcome.
So it's called, your book is Simple Medicine, No More Google Searches. And we know that it's on Amazon.com. Any other formats that where people can get
Barnes and Noble, and it's the BAM and PAL and Indie. It's also at my website at simplemedicinebook.com.
Perfect.
And it's going over well. I just hope, you know, year by year, people can, you know, then you have the hypochondriacs, you know. So I have, you know, these patients of mine have bought it for their spouse or their brother, their sister, their aunt, their uncle, their great Christmas gifts that way. You know, it's a book you're not going to write everything all the way through, but it's always there, you know. And, you know, people will have a clot in the leg, and then, you know, well, geez, why did I have a clot? And I spell out, you know, actually, the only reason I say that is because my editor says, "Oh, can I talk to you about this? Because, you know, my mom just had this," and I write the simple tests I have. But it's just something that, hey, if you have a little problem, go just refer to it. You know, it can't hurt you. The more education, literacy, you know, that you have, and you know, if it can help people, and, you know, I'm not here to say my way is the best way. I'm not the smartest doctor, but I have seen everything. I know what's common. I know at least the basic standard of care, and, you know, you don't have to do exactly what they say, but it's got to be somewhere in the realm. But and I don't see this book, you know, changing that much, except for the new medicines and some of the things down the road.
But that is a fascinating point, because I have contended that if you kind of look historically at healthcare, and we learned in the last 2 years that actually healthcare matters. I mean, lots of people died because they didn't get, you know, cancer screenings and didn't go in for chest pain when they had a heart attack because they were scared of COVID, which never made sense to me, but that's another story. But it's fascinating, because I think, you know, for the most part, medicine, at least Western medicine, plateaued in around 1960. You know, when you think of, you know, we had penicillin by the end of the 40s. We had other antibiotics that came, you know, out of penicillins and those derivatives. So you could treat most infections fairly easily. You could treat more and more as an outpatient. You had good anesthesia. You had reasonably good surgery. You had, you know, sterile technique, et cetera, et cetera. And that all basically peaked by about 1960. So if you ruptured your appendix in 1960, you'd have about the same amount of, you know, chance of survival then as you do now. Okay. You know, if you broke your arm, okay, you know, you'd have about the same outcome. So what's changed? Okay, well, there's some stuff that's way better. You know, joint replacement is really good, and that's a game changer. But it doesn't change whether you survive. It changes whether or not you can, you know, thrive, so to speak. So that's a good thing, right? But then there's a gajillion chemo agents that are super expensive that do basically nothing. You know, you look at these ads on TV, 90 days with end stage cancer for a new agent compared to the old agent. I mean, it's 3 months of having end stage cancer. Ooh, lucky you. You know, 3 extra months.
Yeah, what cost?
And then, you know, the MRIs and the whatever. And it's like everything we're doing is picking away at little tiny percentages of difference. Okay. And it's like, you know, it blows my mind. I call it reminds me of the store I went to in Edmonton when we were residents. And I think the cheapest stereo they had there was about $100,000. And this is in 1993.
But was the sound $100,000 better?
But that was the point. you listen to it and you go, well, that sounds really good. That $200,000 stereo sounds really good, but it doesn't sound like 200 times better than $1,000 stereo. And that's where we are now in healthcare. Like, we're doing all of this super expensive stuff, in my opinion, for marginal gains. Okay.
Yeah.
This isn't like
Does it change?
getting a colonoscopy when you're 50, they find polyps, you're not going to get colon cancer.
Right.
I mean, it's just super marginal stuff, and it's super, super duper expensive. And yet the thing that works the best and makes the biggest difference for diseases of the 21st century is not eating as much and going for a walk and quitting smoking.
Exactly.
Like, hello,
Lifestyle change.
but I had a patient on a novel chemotherapeutic for end stage lung cancer, and she was still smoking. And I was just like,
choices.
How can Medicare pay for this when the thing that you did that gave you the disease, you're still doing, and we're paying like $20,000 a month for this therapy? Like, how is that rational?
Yeah.
Well, I think patients are going to figure it out as the higher deductibles go, the more cash they're paying out of pocket every year, that they're going to have to figure out, hey, let's get a little healthier lifestyle, and let's get primary prevention and quit using these emergency rooms and urgent cares as their primary care doctors.
Amen. Well, I'm going to put the link to your website and book in the show notes. Are you still taking patients or new patients if anybody's in your area?
Yes, I am. We've seen a boatload this year, and there's attrition. Mine can die also and move and leave. So, but yes, I am taking new patients.
Awesome. So if anybody wants to make the trek across the country for you to be their PCP, there you go. Or if you're in the area, I'll look up Dr. Rob. So thanks so much for being on the show. I always just like to ask if there's any last words that our guests have for the audience.
No, I think as a physician, we just want to see the best results for our patients.
Absolutely.
Absolutely.
Excellent.
Awesome. All right.
Thank you so much for having me on the show. Oh,
you are welcome.
It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
While we try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.